Bismillahirrahmanirrahim. I am Dr. Halimullah. Today presenting moving forward for the management of localized renal cell carcinoma. Two options for the localized renal cell carcinoma. We have active surveillance and partial nephrectomy. First, we shall describe active surveillance. Active surveillance is the initial monitoring of a tumor size by serial abdominal imaging and delayed intervention reserved for tumors showing clinical progression during the follow-up. For small RCC in asymptomatic elderly patient with poor surgical risk has provided the opportunity to observe the growth rate of these tumors in a patient who are unable or unwilling to undergo a surgery. A growing body of literature exists regarding the active surveillance for a patient with clinically localized small renal masses, that is clinical T1A less than 4 cm in size. In the largest reported series of active surveillance, the growth of renal tumor was low. Progression to a metastatic disease was reported in only limited number of patients. Active surveillance is not appropriate for a patient with larger renal mass more than 3 to 4 cm in size, poorly marginated, non-homogeneous solid renal lesion, and biopsy indicate a potentially aggressive renal cell carcinoma, except in a patient with a limited life expectancy. AUA guideline 2017 for the active surveillance. Algorithm for the active surveillance are expected management for localized renal cell masses suspicious for the malignancy. Before we going for the active surveillance in a patient, we assess a patient with we baseline assessment of patient factor, tumor factor, and the management related factor. In the patient factor, we assess the patient with comorbidity index, the comorbidity index, and frailty score. Then we assess the patient expectation quality of life scoring system. This can be assessed with 16 condition and one age related factor. And other is a clinical frailty scale by which we can assess a patient, either a patient fit or well or managing well. And another scoring system is quality of life assessment of patient for the physical stage or functional ability before active surveillance. Then we assess for patient with a tumor factor on the CT scan or imaging feature, either a tumor degree of enhancement or infiltrative appearance or vascular or fat involvement. Then the tumor complexity and comparison of period imaging with recent imaging, either mass increases or decreases, and the renal mass biopsy to see the grading of the tumor. Then we assess patient with a management related factor with risk and benefits of the management plan. Evidence regarding the oncological, renal, and peripheral outcome, procedure outcome of each type of the treatment with the ACS scoring system. ACS scoring system is a surgical risk calculator for the surgical risk calculator of the in a patient. Then evidence regarding the expected growth rate or efficacy of surveillance and that triggers and the risk of the delayed intervention. After assessment of these three factors, we make a shared decision between a physician and a patient. After that, we can put a patient on the active surveillance or expected management. In active surveillance, approximately every 3 to 6 months ultrasound or imaging followed, while in the expected management, every 6 to 12 month ultrasound. If on the ultrasound shows an increase in size that is more than 3 centimeter or there is a stage progression, then we can change the management, change the treatment plan. Either in the expected management, if CT scan or ultrasound shows metastatic disease, then we can change the treatment plan.
The concept of active surveillance in any tumor is that you keep an eye on that tumor and you don't just leave it, that we won't offer any treatment. You keep an under observation. If the size is increasing, the stage is progressing, and as we know that 5 mm per year is the growth rate of tumors. If it is 10 mm or it is increasing in size, then you have to take a radical decision, either for a partial nephrectomy or a radical. So you cannot in active surveillance. A very common question, especially asked in prostate, that what is the difference between watchful waiting and active surveillance? In active surveillance, you keep an eye on that disease, and these are those patients that need curative treatment if the disease is progressing. So this is the difference between watchful waiting and active surveillance.
Thank you, sir. Moving forward, AUA guideline 2017 on the active surveillance. In the this guideline shows that we how we can follow a patient with active surveillance. We can follow a patient with physical examination and history that is related to the tumor progression and metastatic disease. Laboratory investigation include the baseline investigation include CBC, UC, PTNR, and tumor marker that show calcium level. And if there is any progression in the renal function, we can send for nephrological review. If there is a acute neurological sign, then we can CNS scan, CNS brain scan. We can advise a patient for brain scan if there is a acute neurological sign. If the patient shows a bone pain or there is an elevated alkaline phosphatase level, we can advise a bone scan to a patient. Percutaneous biopsy is advised every patient prior to the active surveillance. And the abdominal scanning and the imaging investigation are advised every patient in 6 months initially and then after annually. Chest X-ray is advised every patient in annually. Then European Association Guideline 2020 surveillance. This shows active surveillance in active surveillance cohort, the growth of small renal masses in low in most cases and progression to a metastatic disease is rare in 1 to 2% of cases. Recommendation offer active surveillance, radiofrequency ablation or cryoablation to elderly or comorbid patients with a small renal mass. Then moving to a partial nephrectomy. A nephron sparing surgery that entails a complete local resection of tumor while leaving a largest possible amount of normal functioning parenchyma in the involved kidney. Common goal of partial nephrectomy are to cure a treatment to minimal complication and minimal morbidity and preserve a kidney function. A history of partial nephrectomy. Nephron sparing surgery for the treatment of renal tumor was first described by Cesarni in 1890. In 1950, Vermeulen suggested that a peripheral encapsulated renal neoplasm could be excised locally while leaving a margin of normal parenchyma around the tumor. Here are the interest in the partial nephrectomy for the renal cell carcinoma that is stimulated by the advance in the renal imaging, that is the 3D printing images and the advanced robotic surgery, experience with renal vascular surgery and improved method for the prevention of the ischemia. Traditional in the past, the indication of partial nephrectomy were bilateral tumor in a solitary kidney, patient at a high risk for future renal failure, or there is a small tumor less than 4 cm diameter. Indication of partial nephrectomy recently have been changed, have considerably widened to include most of renal masses that can be safely and completely removed independent of their size. Partial nephrectomy is unsuitable in some patients with a localized RCC due to insufficient volume or remaining parenchyma to maintain organ function, or there is a renal vein thrombosis. Here is a recent study published in May, American Urology Virtual Experience, that shows the expanded use of partial nephrectomy shows a promise. Partial nephrectomy may be an acceptable alternative to a radical nephrectomy in a selected patient with high risk RCC and largest renal mass. In this study, 97 patients with a PT3A RCC and no metastasis demonstrated that partial nephrectomy is not independently associated with an increased likelihood of cancer recurrence in a patient with high risk RCC.
What is PT3A? Anybody has any idea? Or at least discussing some rocket science? So now it's a tumor which has involved the perinephric fat or involved the renal vein. Renal vein. So this is a very big statement. This is a very recent study, AUA 2020, and they have partial nephrectomy with with a thrombus in the vein.
Of 97 patients, 11% underwent a partial nephrectomy, while 89% underwent
97, it is 970.
970. Sorry. Patient had a mean age of 64 years, a mean tumor diameter of 7.5 centimeter inside. Clear cell RCC was the most common histological subtype. The median overall follow-up was 20.5 months. Although only 11% were considered acceptable to the treated with partial nephrectomy, these data suggested that well-selected patients may have equivalent outcome with partial nephrectomy even in high-risk cohorts. Another study, in a study of 446 patients with clinical T2 renal mass, a group that considered 73% nephrectomy patient propensity score matched to a 373 radical nephrectomy patients, reported that complication rates were similar for partial nephrectomy and radical nephrectomy patients. Severe complications were more common in partial nephrectomy groups, that is 4% versus 2%, but the difference was not statistically significant. European Guideline 2020 Summary of Evidence and Recommendation for the Treatment of Localized RCC. Guidelines shows offer a surgery to achieve a cure in localized renal cell carcinoma, offer a partial nephrectomy to a patient with T1 tumor, do not perform ipsilateral adrenalectomy if there is no clinical evidence of event to adrenal gland. This is a strong recommendation. Before we plan for patient for any surgical option, we can assess patient with intraoperative surgical planning. Before going to a patient for partial nephrectomy, recent advance shows proceed with 3D reconstruction. This for 3D reconstruction, how we can assess a patient in 3D. Look at here is a tumor in the kidney, in upper bowl.
They have marked the tumor. Now they are going towards the axial images, and then they will calculate the size over there, and then they will try to revolve it to get a 3D image.
Another, we can assess preoperatively with 3D organ printing that saves the patient kidney during a complicated renal tumor removal. Organ printing techniques are similar to a conventional 3D printing, but material here used is a biocompatible plastic material that acts as a skeleton for the organ that is printed. This is a 3D image of a kidney that shows a multifocal tumor in the upper pole at multiple points. Another image that shows a printed model, a 2D dimensional CT scan shows a tumor here, 3D printing of a kidney shows a tumor before.
This is a representation that how in simulation lab you can perform it. You see a patient with a tumor, you print it, and then in the lab you can go and you can practice to remove that tumor completely. And this is how they proceeded in 2017.
Yes. Virtual reality that shows a tumor in the kidney. Preoperative consideration for a patient going to a partial nephrectomy. First, we consider a hyperfiltration injury. When a significant portion of renal parenchyma is removed, then renal blood flow is delivered to a smaller number of parenchyma, which can lead to an increased single nephron glomerular filtration rate that is called hyperfiltration injury. Hyperfiltration. Over decades, the hyperfiltration can injure the remaining nephron, resulting in focal segmented glomerulosclerosis and a clinical manifestation of proteinuria and progressive renal failure. Here in biopsy that is shown. Another is renal ischemia. To minimize the blood loss and allow for adequate surgical visibility, it is often necessary to employ a vascular compression during a partial nephrectomy. There are various options for compression. First is a manual compression, renal compression clamp, that is Kaufman clamp, and another is a selective clamping of renal artery, and end block clamping of the entire renal pedicle. Here show the Setinsky clamp on the renal parenchyma.
Can you please go to the slide again, back? Yeah. Manual compressions, that you can press it. Why a lot of people selectively do it? They compress it, then they leave it, then they compress it, and then they leave it. That is not recommended, because the artery goes into spasm, and if you do that, it will go in more spasm. So your main objective is not to let that artery go into spasm, because what we do is, when we close the patient and the artery again becomes normal, then the small vessels and all, they start bleeding. So whenever you are doing a partial nephrectomy, you have to make sure that when you end your case, your artery is out of spasm. That is why we spray PEPA and local like transplant, that the artery gets out of spasm. If you constantly pull it and leave it, so the artery goes into spasm. So you have to take. And what is Kaufman's clamp? आप सब पढ़ बोलने अगली स्लाइड आ जाएगी इसी तरह. So what is this? Anyone has any idea? We have seen Setinsky. We can trace a Setinsky. Selective we have seen, and block. What is Kaufman? Kaufman clamp. It is just like a Setinsky clamp, a huge one, a big one, and it is completely placed on the kidney like this. And then you resect the tumor, and then you repair it, and then you open that clamp. Nowadays people don't use it, since the vascular surgery has evolved into urology. So this has been stopped. Previously it was being done. So things are evolving because of the help of the vascular surgeons with us. Attempting
Whenever you want to address this issue of renal ischemia, you must be sure that the anesthetist is with you and your surgery is not with um, hypotensive anesthesia. It should be normotensive, if not hypertensive, because that will again lead you, slightly mislead you, to judge whether you have gained some control over bleeding, because that bleeding might be stopped because of hypertension. So there are ways and means of going about this renal ischemia problem. But one thing is very important, that you have to communicate during surgery with your colleague on the other side of the curtain, and that is anesthesia.
Thank you, sir. Attempting to limit warm ischemia to 20 minutes and cold ischemia to 35 minutes helps maintain a renal function. Here the intraoperative ultrasound.
A bit about ischemia. It is a very important topic. 25 minutes is the cutoff time for clamping of the main artery. And if you go from 25 to 35 minutes, there is minutes of ATN to the kidney. 35 to 45, there is hours. And then if 45 to 1 hour, weeks. And more than 60, months. So the kidney will go into ATN for months. So 25 is the cutoff, so you have to keep that in mind. Whenever you start whenever you place the bulldog on the artery, you have to inform the anesthetist, as well as somebody has to record the time. That it is very important and crucial step.
Thank you, sir. Intraoperative ultrasound. Careful inspection of entire renal surface should be done intraoperatively to ensure that intraoperative findings corroborate with preoperative imaging studies. Here we can see how the intraoperative ultrasound.
This is Dr. Craig Rogers, Director of Renal Surgery at the Vatican Urology Institute. Intraoperative ultrasound for tumor identification. Intraoperative ultrasound is used for tumor location and to delineate margins of resection. The assistant introduces the ultrasound probe through the assistant port. The drop-in robotic ultrasound probe has a notch that can be picked up with the ProGress instrument, giving the surgeon control over the probe. The ultrasound machine is connected to the da Vinci system, allowing the ultrasound view to be displayed on the console screen. The ultrasound probe is placed on the tumor and the edges of the tumor are identified. The probe can be moved side to side across the tumor. It can also be moved front to back, defining the tumor border at the tip of the probe. The renal capsule can be scored circumferentially with an adequate margin around the tumor. The lower pole tumor is identified with ultrasound in a similar fashion. The renal capsule around the lower pole tumor is scored at the intended resection margin. In the next video, we demonstrate.
Then we go
Now, a word about this ultrasound. You see, you got to have an eye about ultrasound, because if you have got this knowledge of seeing and interpreting an ultrasound, then it will be easier for you if you want to do it in an open surgery, in an open field, or you want to do it laparoscopically through a laparoscopic probe, or if you want to do it again laparoscopically, but if you want to operate on a robotic platform. Why I'm stressing on this point at many other meetings also, that it should be learned by a urologist, because the urologist is doing the procedure, and it is not always easy to ask your colleague from radiology to come in. For instance, if he comes in or she comes in, it might be easier to handle a probe on an open field, but it might not be easier for that person to operate a laparoscopic probe. You see, once you have got this idea of delineating the interface between a solid area, which is turning into malignancy, and a normal echogenic area or normal echogenicity or isoechogenic area, then you will mark the line yourself. And if you think that there is not conclusive evidence, then you can slightly move that line towards normal tissue. And in that way, you will gain one thing, and that is negative margin. That can only be an obsession of a surgeon. That cannot be an obsession. I'm not doubting the integrity of anyone, but that is something which has to be learned by a surgeon, because he's the one or she is the one who is actually making the decision. So once this ultrasound technique is learned on an open field, it can be very easily translated whenever you want to do on an advanced scale. Now, again, there is always a paradigm shift, and this is a paradigm shift. Now we are moving towards using an ultrasound probe. It has to be learned during residency, and has to be practiced and translated during your other, say, steps of career. But that is very important, and I think we have to move in that direction, that ultrasound-guided biopsies of prostate, kidney, should be in the domain of a urologist, and that is a fact which is accepted all over the world. So we are a little late on that front also.
Yes, and after discussion with Professor Asad, we had a very big discussion that while doing open partial nephrectomies, we should be doing per operative Dopplers as well. And in open surgery, we have started doing it, but we have to make it a habit of doing it in open surgery first, that we know that from where to resect, where to perform and everything. Because most likely, when I was reading the literature, and I am very enthusiastic about watching robotic videos, so the surgeon is doing the ultrasound over there, and his technician is putting the probe, and he's moving it with the in the console. So when you're doing a robotic surgery, then you have to do that yourself. So you have to prepare yourself beforehand for that.
And the second step is in the quest to have efficiency in surgery is to have image guided surgery. So you cannot be guided by image to enhance your skill as dissecting and ablating a tissue unless and until you know how to use your probes, how to use your imaging techniques. So I'm not just negating the presence of a radiologist, but they are the ones who will teach us. But again, it has to be learned by somebody who is actually doing the procedure rather than someone else who can guide you to go into that direction or this direction. So it has to be learned by, I think, by a surgeon.
Thank you, sir. Then essential steps for partial nephrectomy. In the first step, we clamp the renal vascular, and after that, we circumferentially incise the tumor with a rim of normal parenchyma.
How many of you have seen a partial nephrectomy? Please raise your hand. A lot of people have seen. What is different in this picture than what we do? I need somebody very observant. Surgeon should be observant. There is one thing which is different in this picture, what we do. Hey, one at a time. जी 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 बोले बोले बोले. So actually, one thing is we don't clamp the vein. Second one is we don't use the knife. We use small molar. So we have got a lot of observant people. I am very happy that they are awake in surgery and over here as well. So over here the vein is clamped. So we don't clamp the vein. We only clamp the artery. Whenever there is a very huge mass which is very endophytic going towards the hilum, then we place a clamp on the vein, that because of the back bleed and all, that our field remains clear and we perform a good surgery. Otherwise, we don't place a clamp on the vein.
If you know how to use your probe, then this marking will be more shallower if you don't understand your probe. It will be more precise if you know your probe. It would be rather going into a different direction if you don't interpret the ultrasound picture yourself correctly, because then this wedge will be too deep and it will go on to have an overlap on the hilum, you see. So this wedge and the depth of the wedge will always be appropriate when you use your probe to have a marking, and then your dissection, whether it is with a diathermy or whether it is with a knife, it will be precise. By precise, I mean to have negative margin. That should be the obsession. That should be the ground rule. You must have a negative margin. The only way to know and the most appropriate way is to use your ultrasound probe. What anybody can say to me is, for instance, if you take out the tumor, which is in front of you, in front of your eyes, and you don't use the probe, then what you do is you take multiple samples from the area which is left behind in the second picture, big picture number B, and these are sent for frozen section. Now, frozen sections fallacies are, if there is malignancy, it will tell you that there is malignancy. But if there is, if they tell you that there is no malignancy, then they are not sure because they need a little bit of time for their preparation of slides. It might be possible that after some time it turned out to be positive, meaning to say malignant. So you see, a frozen section will always give you correct interpretation in terms of whether malignancy is there, but they can't tell you correctly whether malignancy is not there. So this has to be very clear in everybody's mind. So if you don't want to have that kind of fallacy, you must use your probe. But you can't say that I will not do any, I will not use any ultrasound probe, and I will not do any frozen section, and still I want to do something called partial nephrectomy. Then that is the case which is not on.
Thank you, sir. And then the partial nephrectomy and tumor enucleation. There is a difference between the partial nephrectomy and tumor enucleation. In the tumor enucleation, we remove a tumor along with a pseudocapsule without normal parenchyma. While in the partial nephrectomy, we remove a tumor along with pseudocapsule with a rim of normal parenchyma along with.
When we are operating, we find a pseudocapsule and we place our finger inside and we start dissecting it out. That is not on, and that is why we get a lot of positive margins as well. And when we take out the tumor, we see that yes, it is completely taken out, but slight rim is still present over there. And initially when we started doing it, there were a lot of positive margins. They can come right now as well, but then we started removing the normal tissue as well. The fear of surgeon is while removing that normal tissue, there might be some bleeding. So when we'll be discussing the steps, we'll be discussing how to do it on zero ischemia.
Then the excision of tumor that involving the collecting system. Here in the CT scan, we appreciate a pass and the lower pole of kidney and perioperative finding of a tumor in the kidney. Here we control the vascular renal arteries control. Here picture depicted that how we can close collecting system with a hemostatic agent. Here in the crater there is a bolster placed while two plates are placed and are sutured with a horizontal mattress.
Kidney can be repaired in multiple fashions. We have been reading in the books about bolsters. We don't use bolsters over here. That is like a Surgicel or something like that. We used to place that and they used to get infected, and even post-operatively the CT scans used to pick it that there is some residual mass and ultrasounds and all, and there were collections, so we stopped using it. So we the fat which is present on that tumor is called the toxic fat. You let that toxic fat remain over the tumor. You excise from the boundaries of that tumor, not that toxic fat. It has to be stuck over the kidney, the tumor, and you have to make a plan that the other fat, which is the remaining fat, you have to like we use in the omentum, we make a flap of that fat and you can place that fat, or you can simply repair it as well, like we repair in two layers. We repair the, if there is pelvic calyceal system opening, you repair that, ligate the vessels, and then you repair the cortex. So it can be done like that. In robotic surgery, we use sliding stitches. At one end of the stitch, we place a hemolock clip. We take from bite from one piece, other piece we pull it back, so the kidney shrinks and it's closed. So you can do that in open surgery as well.
Now, all these filling materials, they can be divided into two types. One is the autologous, say, tissue taken out from the same body in which you are actually operating. And that includes a lot of things. For instance, as Haris was saying, perinephric fat, something which is like omental fat, maybe a piece of omentum if, with a supplying vessel. Then you know, then you should know how to dissect out that kind of a sleeve of omentum, and there are ways and means of doing it. The third thing is you can use some muscular tissue from maybe where you are very close to the rib cage. Then you can take out the intercostal muscle, and then you can fill the gap with the muscle, and then you can just stitch it. But I have got a reservation. I want to fill the gap with something which is inert, something which doesn't have the capacity to be biological, something which will not give rise to two things. One, it should not have any infective capacity. The second thing is it shouldn't be something with a malignant potential. Now, with an infective capacity, I mean to say that it should be as sterile as possible, and that can be a bolster. You can make a bolster of yourself by having, for instance, a surgical that can be flipped into 2 or 3 layers. You can roll it, and that roll can be a bolster. The second thing is you can use gel foam, and that is again very much easily available. You can press it, you can cut it into the size that fits your gap. So you just have to just make yourself comfortable with it. These two things have got an edge over biological tissue. For instance, if you have got, as you have said, toxic fat. Now, toxic fat is something which might be a good explanation, which might not be a good, say, explanation of a fatty tissue. Because unless and until you biopsy it, you will not be sure that it is having some new plastic capacity. If you are filling the gap with a new plastic tissue, you are actually harming your own procedure. So you don't want to do it. That is something, again, an obsession. So make yourself comfortable with something called inert, and that inert material, there are a lot of things. You can have it because you open up the pack, and that pack is sterile, so it is sterile, non-infective, non-malignant. So just use it and then see what the results are. I have, throughout my doing these surgeries many years back, I have never used something which is a toxic fat, just because of the reason that I've got that fear in my mind. I have used subcostal muscular tissue on the insistence of Dr. Manzoor Saab, because he taught me how to use it. But what Altaf Saab was doing throughout, I think most of his cases was actually bolsters, not the toxic fat. So I think there is a difference of opinion and experience also here. But evidence-based, that will run the race.
Thank you, sir. And the other type of partial nephrectomy, wedge resection of large cortical tumor. Here is a cortical tumor in the cortex, and there is a resection of tumor essentially incised cloaca of collecting system and bleeding vessel. And similarly, we can fill the gap with placid and surgical. Segmental nephrectomy of large polar tumor. Similarly, we can first control the segmental renal artery and vein, and after demarcation of segment, after demarcation of a segment, then we can excise a large polar tumor.
In this picture, we can appreciate that the segmental vessels which were supplying to that mass were dissected out and then ligated. So it makes your life easy. There is less bleeding while dissecting and all.
Then moving forward, comparison of different surgical options for partial nephrectomy. First, we compare the open partial nephrectomy versus robotic partial nephrectomy. There is a study published in 2014 in the World Urology Journal, open versus robotic assisted partial nephrectomy in the multi-center comparison study of perioperative result and complication. That concluded that robotic partial nephrectomy was associated with a significant reduction of blood mass, blood loss, surgical complication, including the reintervention rate for urinary fistula and postoperative bleeding, and with a shorter hospitalization. Then we compare the robotic partial nephrectomy with laparoscopic partial nephrectomy. There is a study published in 2016 in the Journal of Urology that shows the outcome of robotic versus laparoscopic partial nephrectomy. That shows robotic partial nephrectomy confers a superior morbidity profile compared to a laparoscopic partial nephrectomy in most of the examined perioperative outcome. Another study that published in 2013 in the Journal of Endourology that compared the cost of robotic, laparoscopic, and open partial nephrectomy concluded is by minimizing the operative time and hospital stay, the robotic partial nephrectomy and laparoscopic partial nephrectomy can be the cost equivalent to an open partial nephrectomy. Regarding variable cost, When including a fixed cost, the robotic partial nephrectomy and laparoscopic partial nephrectomy were more costly than the open partial nephrectomy. Robotic partial nephrectomy can be the new gold standard. Advantages of the robotic partial nephrectomy: superior operative ergonomics of surgeon comfortably seated on the control side. There is a micro wrist mimics the motion of a human wrist. Binocular system and polarizing filter creates a 3D view. Surgeon controls the camera and scales down the overall motion of surgery. There is a study published in 2017 December that show renal ischemia and functional outcome after robotic assisted partial nephrectomy. There is a zero ischemia and selective artery clamping provide the best functional outcome following robotic partial nephrectomy.
Ischemia time is an imperative issue here. Also, multiple arteries, so we're going to be able to use selective clamping, exposing with ultrasound all three tumors. And then this is on-demand ischemia, which essentially is just cutting the tumor until it bleeds, until you start to lose visualization, and then clamping. So it just shaves off a few precious seconds. So then clamping just the vessel that's going to the lower pole tumor that we're going to be cutting first. Once that tumor is out, then clamping the next vessel that goes to the other two tumors, which will be resected on block. Tumor, the more you're going to get bleeding like this. And so once the idea is that once these are resected, then...
So this is how we do open partial nephrectomy on zero ischemia, that whenever you cut the tissue and that cortex starts bleeding, any vessel comes, you take a stitch and suture it. Whenever the problem we face is that at one time you should have one enemy. That once you cut it, there should be one bleeder, you should be ligating it properly, stitching it properly, that once you cut more, the other bleeder can be controlled separately. What most of the people do, they land up in a problem, they start cutting the whole tumor, and then there are 5 bleeders, and then there is a havoc going on what to do, and then they pull the artery, then they put a bulldog clamp. So the main principle is that on zero ischemia, that you cut the tissue, you ligate, you cut the tissue, ligate. And he was doing the same thing on zero ischemia in robot. I asked a robotic surgeon who used to come over here that what is the limitation of robot and what can be done or not. So he said that whatever can be done with open surgery can be done with robotic surgery or laparoscopic surgery. It all depends on the skill you have. So he has shown that while doing it with in robotic surgery as well.
And moreover, one word that which was used by the person who was doing it, and that is on-demand bleeding. Now, that is the same thing when you demand bleeding to occur in front of you, then you get yourself prepared with the needle in the needle holder and the extra needles very close by, maybe on the upper side of your abdomen. So you have to be very quick then. The second thing, again, anesthesia. Hypotension is something which will conceal it. Hypertension, on-demand hypertension, as well as maybe no normal blood pressure. It can give you an edge. Otherwise, when you go out, you will not be able to understand what happens to the patient in the recovery, whether the patient starts bleeding or not. Maybe the patient starts bleeding when the patient is in the ward after some time, maybe after 3 hours. And that happens. That happens a lot. I think that is something which happens to the extent of maybe more than 50% of cases. That is just because of the reason that this on-demand bleeding is not being practiced as a rule. If you want to play the game, then you have to make the rules a little stricter for yourself. This is something which is scary. This is something which demands a lot of expertise also, but it is something which is most beneficial for the patient if you want to do partial. If you want to do radical, there is no problem. If you want to do partial and zero ischemia, then this has to be done.
And whenever we take these things lightly, we lose the patients, and we had an incidence as well. So we need to be very vigilant regarding that. You do a very good surgery, tumor-free patient, and he's in problem because of bleeding. This can be prevented.
So you should act like a Braveheart.
Right.
This is an example of different cooling techniques. So you're going to clamp the artery and the vein. This is ice supercooled saline that's put in the refrigerator overnight, in the freezer before the case. This is a sigmoidoscope using bringing ice slush in. And now we use a plunger that we developed for Innovation Institute that just allows us to load more ice, clamping the artery and vein again through the gel point, allowing large volumes of ice to be put around the kidney.
This is about cold ischemia. Warm ischemia, you clamp the artery. Cold ischemia, you place these ice packs around the kidney. You can do it open, you can do it in robotic. And what is the advantage? That you can extend the ischemia time. From 25 to 35, 40 minutes, you can extend these 15 minutes if you place this as well. So we are not doing so much complex surgeries, we are not using it, but I guess we should be using this as well. What's your take on it, sir?
Yes, you must. But again, the principle should be clear in your mind. Ice slush and creating an environment of low temperature is not to hamper bleeding. It is something to go with ischemia, right? So these are two different things. If you want to create an environment where you want to have a bloodless field, that is not the requirement of partial nephrectomy. The requirement of partial nephrectomy and the bottom line is ischemia. You should have as low as possible because you don't want to have ATN. You don't want to lose the kidney, right? So that is something. And for instance, it might be possible that somebody who is actually listening to us will say that they are both talking something which is not important. This is the most important thing. Otherwise, you don't go towards this procedure which is called partial nephrectomy.
Then the function of the partial nephrectomy. Quality of parenchyma surgery is a non-modifiable factor, and the quantity of preserved parenchyma and warm ischemia are modifiable factor. We can preserve parenchyma as much as we can do in partial nephrectomy. We can prevent warm ischemia time. We can minimize the warm ischemia time during surgery. These both are the modifiable factor that ultimately determine renal function after partial nephrectomy. Tools for surgeon in the autonomy in robotic surgery. There is a firefly technique, robotic ultrasound, robotic Doppler probe, and robotic bulldog clamp. This is insert is a firefly technique in the robotic partial nephrectomy. There is a new camera head can pass a fluorescent signal in the robotic camera. The fluorescent signal overlaid with a green hue in a surgeon console. The laser in the camera excites indocyanine green and fluorescent. Indocyanine green is a dye that is a medicine that we inject in a patient with a IV, and after that when it comes in the renal vascular, that dye can be visualized with a laser camera as a green. This is a technique.
There are three main types of robots: S, SI, and XI, and now they have launched X as well. XI has got this built-in. SI, you have to get that built-in. XI has got that built-in. The camera, you turn it on the Firefly mode, it turns it automatically. In SI, you have to buy that thing and place it inside. The camera has got that laser. Video, what do you call it?
ये वीडियोस
Going green is taking on a whole new meaning at Shawnee Mission Medical Center. On October 17th, see how Firefly fluorescence imaging helps surgeons do a robot-assisted partial nephrectomy. The color enhancement improves visualization when removing kidney tumors.
The dye, then with use of a black light, causes normal tissues to look green. Abnormal tissues are dark to black. So we can differentiate the normal tissue from abnormal tissue. So by using that, then we can delineate the margins around the tumor when we're actually doing the dissection.
Shawnee Mission Medical Center surgeons have performed more than 1,500 robotic procedures. Learn more about the Firefly imaging and the advancements in robotic surgery at Shawnee Mission Medical Center. This program will be available online October 17th at noon Eastern Time.
This is the complete ischemia. There we can see when the renal vascular arch clamped, there is a complete ischemia. While selective clamping of renal vein or renal artery or segmental renal artery, there is a demarcation. This is a normal parenchyma that visualized as a green, while dark visualized as a tumor. Either dark.
We have done these techniques in open surgery as well, and you dissect out the segmental vessels, you place a bulldog clamp on the segmental vessel which is feeding the tumor, and the kidney in that area becomes pale, and you know that how much tissue, normal tissue you're going to lose if you ligate that vessel. So then you decide that should I ligate this vessel or I should dissect the tumor, and we can place a clamp on that, doing a selective, and then you can place dyes in the vessels as well, and the kidney can lighten up. These are the maneuvers which can be done for complex tumors and which are endophytic tumors. Ultrasound can be used to localize it, and these maneuvers can be done to save as much tissue as possible.
Robotic ultrasound that we seen during a partial nephrectomy. Urological complication after partial nephrectomy. These are the urine leak, most common complication after partial nephrectomy that can be managed easily by placement of a retroperitoneal drain for 7 to 10 days, and in some cases it requires a retroperitoneal drain and peritoneal catheter. Another complication is a postoperative bleeding, and third complication is renal insufficiency. These are complications can be managed conservatively. Rarely they may require reopening. EAU guideline 2020 summary of evidence and recommendation for partial radical nephrectomy and partial nephrectomy technique. These guidelines offer a laparoscopic radical nephrectomy to a patient with a T2 tumor and a localized masses not treated by a partial nephrectomy. Another is a do not perform minimally invasive radical nephrectomy in a patient with T1 tumor, for whom a partial nephrectomy is feasible by any approach, including open. Another is a do not perform minimally invasive surgery if this approach may compromise oncological, functional, and perioperative outcome. Then we see the positive surgical margin on histopathological specimen of a resected tumor after partial nephrectomy. A positive surgical margin is encountered in about 2 to 8% of partial nephrectomies, and study comparing different resection techniques are inconclusive. Most trials showed that intraoperative frozen section analysis had no influence on the risk of definitive post-surgical margin, and the local tumor bed recurrence was found in 16% in positive surgical margin compared with 8% in negative margin. Patients with positive surgical margin should be informed that they will be subjected to a more intense surveillance and a rate increase of local therapies. However, protection from recurrence not ensured by negative surgical margin.
So, a few things about partial nephrectomy which are important, that it is not only the surgery that what you are cutting and what you are repairing. It is about preserving the renal function. You should look into partial nephrectomy in total from operative planning to per-operative planning, and then post-operatively you have to keep an eye on that. Whether you do open, laparoscopic, robotic, but the main function of that surgery is to preserve the renal function with negative margins and no good oncological control. So in total, these all maneuvers, these advances are being done to improve these things in a patient, that He's tumor free along with safety margin, and newer techniques are being introduced. Robotic surgery for partial nephrectomy and prostates have got a very good value, and they are the future. And this is how you have to go about it. Look into the patient in detail from pre-operative to post-operative, and that is how you manage it.
Thank you, sir.
Thank you very much.